everyone. Dr. Tara Dominguez here with TD Pharmacy Services. I have a very special guest for you today. This is Dr. Alexis Ngo. Alexis is a Pharmacoeconomic Specialist, which is just an absolute mouthful. And she is an amazing person. And I am so lucky to have known her, especially going into doing my own business with COVID testing and coding. And in the beginning, when I was figuring it all out, I think I was talking to you almost every day. I was in your office all the time. So she has so much knowledge, and I cannot wait for her to share it with you today. Alexis's background, she did her fellowship at CMS and CMS? No. CHS, sorry, CHS. And she moved to Oklahoma 2 years ago.
Yeah.
Right?
I can't believe it's been that long.
I can't believe so either. So she has been working for a big health system here in Oklahoma City, and she's just doing amazing things, helping them save money. And I'm so very fortunate to know her and know this side of pharmacy, because this is never in our wheelhouse. We didn't learn this in pharmacy school. It's not something we're really taught unless you go to work for someone who this is your job. So I feel like she can really teach all our pharmacists out there and patients too, a lot of information about insurance payments, contracts, and reimbursements, which, so much fun, especially going into a new year in 2022, because everything changes all the time. So one of my first questions to you is, there are many new graduates out there and pharmacists in general that find themselves in like these clinical roles like I did, and not having a clue about any of the, the back end, the money, the reimbursement, the contracts, the payments. You're dispensing medications, and you're just, that's what you're meant to do. And that's what you're doing. But, sometimes as pharmacists, we want to be more familiar with how insurance works, but we don't even know where to start. So where do you recommend other pharmacists starting to learn more about this?
Yes, I think that's a really great question. And when you start to get into this area, there's a lot of jargon. And I read an article a couple years ago now in Pharmacy Practice News. And in the article, the recommendation was to learn the language. And that really has stuck with me throughout all these years, even now. And I think that's really where pharmacists can start. As pharmacists, we're used to using technical jargon all the time. We use words that most people are unfamiliar with. We throw around things that, other folks don't know what we're talking about. We're accustomed to technical jargon, but the language used when you start talking about reimbursement, revenue, contracts, even drug costs are unfamiliar to us. So when you start to enter into this space, if you really want to understand the principles and the concepts and apply those concepts, you have to understand the language. You have to know what a HCPCS code is. You have to know what a MAC list is. You really have to understand the basics, and then you can jump into applying those basics to your setting of care.
No, that's really great information, because when I got out of pharmacy school, I had no clue what HCPCS code was. And then I kind of had to start learning it. And then Alexis made me very, very aware of it with all of our, very high priced drugs and exactly how we code them. And yeah, so I'm so happy and fortunate to other pharmacists like you out there that are helping others understand these things. So many pharmacists in the outpatient setting are faced with difficulties when it comes to getting paid for their patient care services. We unfortunately as pharmacists, we can't just bill for our service like a physician can or a nurse practitioner. But hopefully that will change one day. That's the hope. So what approach do you take when trying to understand the reimbursement for pharmacy services? Because I'm sure many of our listeners and viewers would love to know that.
I think the first step is really understanding the services that you're planning to bill for and the setting that you are providing those services in. So there's a different variety of ways that you can bill for your services, and it really depends on what you're looking to do and how you're looking to do it. So really looking at your options, understanding the different options that are available to you and what works best for your practice is going to be the first step. So there's different options, as I mentioned. One is doing incident to billing. There's options of directly billing the patient for your services. There's also the options of doing things like super bills. But you really need to know what's going to work for your patient population. And part of understanding that is understanding who your patients are and what services they're looking for. It's important to understand your payer mix. So are you with a patient population where you're mostly going to be reimbursed by private payers? Are you with a patient population where your patients are mostly Medicare, Medicaid? Understanding your patient population, your services, and then your setting of care is all going to help you determine, how you're going to approach billing within your care practice.
That makes a lot of sense. A lot of pharmacists out there, they work with Medicare patients. So they're in remote patient monitoring, chronic care management, and different things like that. So, what recommendations do you have for those patients that are kind of new to patient or physician services? And that's their main patient is the Medicare patients.
So when they're working with Medicare patients and when you're working specifically with a provider, if that's in a provider clinic, there's one of the options that you can look into is incident to billing, which I briefly mentioned earlier. And that is when you're providing services to a patient incident to a physician. So what that really means is when you're providing services under the direct supervision of a physician. And when you do that, you can bill for your services using different codes. And that goes back to the idea of knowing the language and knowing what codes that you want to use to reflect your services for that provider. And different codes carry different reimbursement rates. So if you bill for one code, you might get paid X amount, whereas if you billed for another code, you might get paid a greater amount. And those codes should reflect the services that you're providing to that patient. So I think that when you're looking to explore clinical partnerships with physicians, that's one avenue that you can look to help understand how you're going to get reimbursed.
Yeah, definitely. Because it's important for us to get reimbursed for our time, but appropriately too. The reality is that you're not going to be spending an hour plus with these patients every time you see them. That's just not the reality. So you definitely want to make sure and stay in your lane with billing for your services as a pharmacist, which is a fantastic thing that we're allowed to even, to do that. So I would definitely say other pharmacists out there, don't be intimidated to try this out. Especially in physicians' offices, they're a little bit more familiar with billing, so they can easily help you kind of navigate that and figure out what that looks like for you, even though as pharmacists we're not as familiar with billing for our services. So if you explore those options, definitely talk to the clinical the manager of that practice and see what you can work out with them. So you did mention HCPCS codes. That's a fun word.
Yeah, it's a mouthful.
And CPT codes, which I'm more familiar with CPT codes. Can you elaborate on exactly, what those are and how you even go about looking them up to even know okay, this code means this, but what should I even be, billing for? How much is it worth? And, where do you go to find all that information out?
So the CMS website has a really great primer just on HCPCS codes. It tells you the definitions, what all the numbers stand for. And they have an addendum on the website. I refer to it as Addendum B, and that's what it's called. It lives on the CMS website, and it defines all of the HCPCS codes. So when you are looking for a HCPCS code for a drug per se, typically those are J codes, sometimes there are Q codes, depending on what you're looking for, but they are all 5 characters. When you have a HCPCS codes, and CPT codes are the same, they're all 5 characters, and they depict your actions towards a patient. So one of the things I think is really neat about coding and understanding coding is you think about a visit with a patient. Everything you talk to the patient's conditions, if you give the patient an immunization, all of that is distilled down to codes. And the codes reflect what you and the patient are doing with that encounter. And that's similar in a hospital and can be similar in a clinic. And we have several different coding methodologies to help us illustrate what has happened during that encounter. HCPCS and CPT codes, when applied to medications, illustrate those concepts as well. So if you have a medication that you're providing and you list that medication on your bill, you're effectively telling the insurance carrier what service you have provided to this patient. So the drug itself will have a HCPCS code for these separately payable drugs. And then there'll be a HCPCS or a CPT code for the actual action of providing that drug, if it's an injection, and so on and so forth. So you can get paid if it's a separately payable drug for the drug itself, but then also by coding it correctly, you'll get paid for the act of administering that drug. If it's in, depending on the location where you're at, and the route of administration. So I think it's really important that when you're looking at these and you're trying to decipher which ones to put on those claims, that you understand that there's a lot of different codes that you can use, and that really reflects how you are treating your patients and what services you're providing. Of course, then those codes are supported by diagnosis codes. Most of us have heard of like ICD-10, and those are the diagnosis code list. So basically, when you are looking through these codes, you're painting a picture. You're painting a picture of, this is what I gave the patient, this is how I gave it to the patient, and this is why I gave it to the patient. And that's how I like to think of HCPCS, CPT, and ICD-10 codes all working together to illustrate what has happened during that encounter.
Right. And then you get the fun thing about a modifier.
Yes. And then there's modifiers. So there's a ton of modifiers.
Mhm.
Modifiers can help differentiate routes sometimes. That's when you see a modifier. So what is a modifier? Well, a modifier is appended to a HCPCS code and to provide really additional detail. So in the setting with drugs, a common modifier that we see is a JW modifier, and that stands for waste. So that's to indicate that you gave a dose, but perhaps you only give half the dose, and then the other half was wasted. And then you can get paid on that waste for separately payable drugs. And that would allow you to recoup some additional reimbursement rather than just the reimbursement attributed to the initial administration, depending on the drug and the billing units.
Sure. So there are so many drugs out there, especially, monoclonal antibodies. And then there's just so many different things that come in bulk and you might have to waste. What are some common things that you see that you're having to, waste in the inpatient setting or outpatient setting that you need to apply those codes to?
Yeah, so I think in the outpatient setting particularly, you're looking to apply these JW modifiers, these waste codes, to drugs that are maybe weight-based dosing, because one size doesn't fit all. So you might have a drug where a billing unit is equivalent to 1 milligram, and you have a 100 milligram vial. The patient's dose might be 75 milligrams. So you would, on your claim, what it would look like is you would have your HCPCS code to tell you what drug you're giving. You would have the number of units that you gave the patient, say 75 milligrams. And then you'd have another line for 25 milligrams with that JW modifier appended. And what that appending of that modifier, what it effectively does is allows you, if the insurance carrier permits, which Medicare typically does, if it's an outpatient reimbursable medication, for you to get some reimbursement for that waste charge so that you're not having to, just associate that to the cost of doing business.
Yeah, sure. Which can be very expensive in some drugs that are weight-based and you just need like a little bit, or you need multiple vials, take a little bit from another vial. So that's awesome advice. So it saves people a lot of money, a lot of pharmacists, a lot of money in their practices. So thanks for sharing that. So there are a lot of different codes, like we talked about, and we talked about why they're important. Is it important in a certain way to actually, like when you're doing your, CMS 1500 billing, to put them in, like, do you have to stack them a certain way, or does it matter, or is it all tied to that, like, just diagnosis code? So like if you had like a physician's visit and then you gave, say you gave them a COVID vaccine while they're there, does it matter how you put that on the bill so much, or does it matter more that it's on there and you have the diagnosis associated with it?
A lot of it will do with what system you're using and how it's processed. I would say that overall, when you're looking at these and you're looking to apply codes to claims, it's very system specific in what your system will accept, whether you're transmitting your claim ultimately electronically, if you're using a super bill, your mechanism of how you transmit that claim to your payer is going to be important in dictating how the coding will work ultimately. One thing I would think when you're thinking about how am I going to code this claim, or what codes can I expect from this visit, I think an important thing to remember is that we want to make sure our coding is accurate, and for two reasons. The first reason is that we want our services to be reimbursable, right? So if we put wrong codes on claims, that's not going to work out.
Right. And wrong locations is another big thing too.
Exactly. Yes. Wrong modifiers. So if you have the correct code the first time, that increases your likelihood of getting paid the first time. And that's beneficial so that we don't delay payment. You can resubmit claims, right? But we want to limit having the need to actually do that because it delays payment. So we want to get our reimbursement in a timely manner. We don't want to have to pay any fees for resubmitting claims and things like that. So I would say that's the first thing to think about when you're looking about how you're going to code claims, is to keep that in the back of your mind. The second thing is we have to be very cognizant that there's compliance risks to coding claims, right?
Sure.
It is not 100% straightforward. The rules are complex, and even intentionally or unintentionally, upcoding of claims can occur. So what's upcoding? Upcoding is where you list a HCPCS code or whatever coding system you're using on a claim that may not reflect what was actually occurred. And when this happens, you can be at risk for compliance in violation of the False Claims Act or various other state or local federal regulations, where you could have put a code on a claim, received reimbursement that you should not have received. And that's a serious thing. And I think when we're talking about claims and we're talking about coding, we want to maximize our coding because we want to receive the reimbursement that we're due for our services. But you want to make sure there's no upcoding. And like I said, most people don't intentionally try to upcode things. That's just one of the things you have to be aware of when looking at this and deciphering all this information to make sure that your claims are accurate and that your coding is truly reflective of the services that are being provided per the rules and regulations.
Oh, that's wonderful advice, because all of us, we want to keep our license and keep our practices. So, if in doubt, I think the best thing to do is look it up, make sure that you can back it up of what you're coding. And if you think that, hey, I'm not quite there, then go to the lower code. And so if you're billing at those very, very high codes frequently, you probably really need to look in to make sure you're following the guidelines.
Absolutely. And the guidelines are important. I think it's also important if you have peers that are in a similar space to talk to them. This is a very complicated space that this is in. And a lot of us aren't taught this. We don't have a primer on HCPCS coding. I know I learned it on the fly. You've learned it on the fly. We really are doing our best to navigate a naturally complicated space. And even when we talk with our colleagues, maybe in revenue cycle or in different divisions, we all have similar challenges with understanding and making sure we're applying the rules and regulations correctly. And the rules vary payer to payer. So it is a complicated space. I think it's important to be cognizant of what you're doing and how it's being reflected.
Absolutely. That's wonderful advice. I love that advice. That's the same thing you told me when I first started into this. So I have become very, very educated on all the codes that I use. So let's change the subject a little bit and talk about contracting, because that one's a big one. And especially being the first of the year, people are coming up with their new contracts and, things are changing. So typically, pharmacists, we don't learn about this in school, just FYI, like there's not like a contracting class that we take or anything like that. Sometimes I'm sure we wish there was.
Yeah.
So the language is a bit unfamiliar to us naturally as pharmacists. So how do you approach managing contracts, especially for, pharmacists who are, maybe sole proprietors or who do have a pharmacy that's very, very busy and they're having to work in it. So how do you approach like really digging in and understanding your contracts in general?
I think it's really important when you start to approach a contract to understand what the contract is for and what the deliverables are and the terms. I think that anybody who starts to read a contract has a tendency maybe to fall asleep a little, especially when you're on page 5 and it's still going and there's a lot of legal jargon.
Yes.
And a lot of times these contracts are handed to you. You aren't sitting there drafting them because, first of all, you're not a legal person by training. And so you shouldn't be expected to, but you're handed a contract perhaps from, a PBM, or you're handed a contract for other things that you're utilizing. And it's a lot to take in. So I think that the best advice I've ever received is the most simple advice I've ever received. And it was called just read it. And when someone gave me this advice when I first started, I was like, how am I ever going to understand this contract? And my boss looked at me and he said, well, you're going to read it. And I thought, I guess I am. And I did. And that really is the first step. They're monotonous. There are lots of legal jargon, but we can apply our knowledge and our awareness of our pharmacy and how things operate, and you can get through them. So I would say there'll probably be some Googling involved where you have to look up specific terms, but overall, understanding the terms. So like, what are the terms you have agreed to? Understanding the deliverables, understanding the impact for this contract. If you don't meet the deliverables, what does that do? Does that cause you to lose pricing on something?
Right.
Does that have no impact? Do you not get a rebate? Do you get a better rebate? You really have to understand what is at risk financially if you don't meet the terms, as well as, what could you gain by meeting the terms? I think that contracting with PBM specifically is very tricky. I mentioned before, sometimes you're just handed a contract, and unfortunately, that's really the term, is you are just handed that contract and you have to review it and look and understand what the terms are. But we have a difficult time negotiating with that when the PBMs are such a large space. So what do? I think like what I've seen to be the most successful is understanding the terms, really putting a grasp on what you're trying to achieve, and then continuing to legislate both at our state and local levels. We've seen some progress in this space recently over the past few years. I would say that hopefully that continues to go in the right direction. But until then, it's really up to us to be knowledgeable about what we're committing to.
No, I think that's great advice. Just read it. Unfortunately, sometimes that's the best thing to do. And then trust your gut. If you see something that you're like, I don't know exactly what this means, ask questions, because a lot of times, I'm guilty of this. Like, Apple will be like, oh, here's the new contract. If you want your upgrade, you got to sign this 52, page document. I'm like, I just woke up. I'm going to go through and sign. But in reality this is your money. This is your patients. This is your livelihood. So make sure you're reading those contracts and understanding the impact that it has on you and your business, and make sure that's sustainable for you. Because at the end of the day, we all have to work and we all have to make money to live. And we want to make sure at the same time we're helping our patients in the best way possible. So, make sure you are reading your contracts, asking questions, and asking a lot of questions. And if you don't know the answer, keep on asking until you find the answer. And sometimes that can be the hardest thing, but, and then, maybe it's not the right contract for you. And maybe you could do better doing something else. So definitely, I love that advice. Just read. So speaking of PBMs, so in the pharmacy space, we do hear a lot about PBMs. We're talking a lot about PBMs more and more and more. I think it's starting to catch a little bit more wind of our patients, too, about what this is. But it's really difficult to explain their role and what, and who these are. These people have came about in the last, 30-ish years. So it's not something that's always been around. It's fairly new. So how do you explain what a PBM is to a patient who may be confused about their insurance coverage in general? Because I'm really confused about mine sometimes.
I think that's really common. You see a patient, they think they have one insurance, and they get to the pharmacy and you ask them for their pharmacy card, and they look at you and they hand you their medical card, right? I think there is just a level of confusion with the pharmacy benefit, and that does relate to the PBMs and their role. Explaining that to patients, I think, can be really helpful for them understanding their med costs, understanding their pharmacy coverage. So I guess if I was asked to explain a PBM to a patient, I would explain it something like this. I would say that a PBM, first of all, is a pharmacy benefit manager. And effectively, they are the administrators for your pharmacy coverage through your insurance. So what this means is that they help determine what medications are or are not covered through the plan that you have. And as a part of that, they also determine the co-payments that you're going to pay as a patient for the medications that are covered. So with the PBM, what you can expect is that they contract with certain pharmacies, which is why a pharmacy that you may have been going to for a long time suddenly no longer accepts your insurance, because they contract with specific pharmacies. You can also expect that they have their own pharmacies in terms of mail order pharmacies. A lot of PBMs will have mail order, which is why the pharmacy people might contact you that's not your normal pharmacy, talking to you about getting your prescriptions from a mail order. So because the pharmacy benefit managers, these PBMs, are involved in your care and have that element of involvement through determining the medications that are or are not available, we work with them collaboratively to try to make sure that our patients are getting what they need for their medication therapy, and that the medication therapy is effective for their condition.
Yes, I think that's a great way of explaining it. And it's a really hard thing to understand, especially at the first of the year, and all of a sudden you were getting to go, one pharmacy, and now they're saying everything has to be mail ordered, or everything has to be sent to a completely different, chain pharmacy. And it gets very frustrating and confusing, especially when you fall in love with your pharmacist and you're like, I don't want to leave them. Why do I have to do that? Now in Oklahoma, I know that we have the right as patients to choose what pharmacy we fill our medications at.
Mhm.
So if you are listening to this and you're in Oklahoma, you have the right to choose what pharmacy.
Mhm.
So you have the right to go to an independent pharmacy. You do not have to go to one of the big chains and fill your medications. So if you ever need some recommendations for some independent pharmacists, I have plenty of wonderful pharmacists that own small business retail pharmacies, and I would highly recommend that you go to them because you will get the best care and best knowledge out there, and they really, really do care about their patients. Not saying that no one else does, but they really take the time to get to know you and want to make sure you're getting the best service possible. So what are some general tips you have for pharmacists that are wanting to start exploring this side of the business with the contracts and reimbursement and all those things? What tips do you have for us?
So when you think about all that we've talked about today, it's a lot.
Yeah.
there's a lot. There's a lot of rules. There is a lot to comprehend, and it's on top of this great clinical knowledge that we have. And it's just applying that clinical knowledge to a totally new area. So when I think of doing that, I think the first tip, as I mentioned when we first started, is to really understand the terminology. Really look into the things that you're going to be working with. Understand the impact of a DIR fee. Understand those words that sometimes gets tossed around and we've taken for granted, but what do they truly mean? Can you understand and apply the language? I would say the next tip is to know your service lines. We mentioned that at the beginning when determining our billing methodology, but I think it's important once you have established your services to know what services are financially feasible for your practice. You might have a service line that isn't returning the profits that you need to maintain your business. So one thing that always surprises me when I talk to pharmacists is they'll say, oh, we offer this service. And I'll be like, okay, great. Like, is that service profitable? And they're like, oh yeah, it's profitable. It's like, okay, well, how much is it profitable by? And we don't know. We don't know what our reimbursement is. We don't know what our profitability is on independent service lines. And I think when you're trying to be more fiscally responsible and understand your operations better, it's really important to know, okay, this is what makes this amount of money. This is good for this is good, and really understand that breakdown so that you understand your health as a business.
Yeah, I totally agree. Because if you're paying a pharmacist, $50 an hour to be your clinical pharmacist, and you're billing a patient and you're getting like $60, for that hour of care, that might not be as feasible of a service, and you might need to figure out how to, optimize that. Or, if you need to kind of switch directions and go a different way. I feel like, for the most part, Medicare kind of will help direct you into what they see patients having the most benefit in. So that came about, especially with remote physiologic monitoring, RPM services. They were paying very, very well for that because they see the benefit in keeping the patients out of the hospital. And the patients, of course, see the benefit too, because they're being monitored in real time, and they're getting to talk to the pharmacist too, at least monthly, if not more than once a month, about what's happening. Why did your blood pressure go up at this time? And, why did your weight increase? And then we're being able to keep people out of the hospital by managing it a little bit more closely. So definitely stay on top of those things that, Medicare is coming out with and what they're paying. And that can really, really help drive your clinical services, for the next year.
Exactly. And it's all about calculating that return on investment.
Mm-hmm.
So sometimes it's not exactly the direct money you have in your hands at the time, but it is an investment. And you have to understand, like, what is your return going to be on that investment? And is that going to be long-term or short-term profitable for your business? But you have to understand the numbers.
Mm-hmm.
And I think that's where, we can really do well in this area, and where I've seen people have a lot of success.
Yeah, absolutely. So you mentioned, changes in the marketplace. What changes do you see affecting pharmacies related to billing and reimbursement, especially as we get into 2022?
Well, we could probably sit here and have a whole nother conversation about COVID billing and reimbursement, and just all the changes we've seen with COVID and monoclonal antibodies, and just the changes in the rules. So I think we've all talked a lot about COVID though, so I'll let that one go for now and just kind of think about in a post-COVID thing, what we started to see before COVID and what we are continuing to see throughout the pandemic. And I think one of the things that I've noticed of a change in the marketplace is the whole concept of specialty medications. It's an interesting concept. It's very hard to define. There's a lot of definitions out there on what constitute of specialty medications. But I think when I finally finished reading a monograph for a new drug that's been FDA approved from a new monoclonal antibody or a new specialty drug, another one is approved.
Right?
Yeah.
So true.
We're just seeing a lot of influx of these specialty medications into the marketplace. And I think what we're going to start to eventually see is some of that shift. I mean, there was a period of time not too long ago where going to a pharmacy and getting, a sub-Q injection or by your pharmacist would have been very odd, very unheard of. And now we're starting to see some of that with pharmacies being able to provide specialty medications. We're seeing specialty pharmacies operated by, regular pharmacies, but also by PBMs. We're seeing a lot of changes in the specialty space. And what I think is interesting is we're seeing a lot of spend in the specialty space. So when you have a lot of dollars that insurance companies are spending to take care of patients, you know that there's eventually going to be some type of change to help control that spend. So where do pharmacies fall? Yeah. And I think that's really what we're going to see over the next couple of years is that change and that adoption of more specialty medications for our patients. And I think we need to keep an eye on that. I think that's going to be really important.
No, I absolutely agree because, back to the whole thing about, like the reimbursement too, and making sure you have the correct modifiers on there for the waste, because all these specialty medications, they kind of play into that world of, of wasting, and, you want to make sure you're getting proper reimbursement for them. And then that you're also choosing the right one to carry, for your patients in your pharmacy. So that's really great advice. Well, do you have anything else you would like to share?
Well, I would just like to thank you so much for your time today. I know this is a difficult subject matter and it's really tricky. And I think having these conversations and having more people and more pharmacists involved in understanding will really help our profession in the long run. So thank you for hosting this. I think it's been really valuable.
Oh, I appreciate you and your knowledge and your time and your expertise, because many of us out there, probably almost everyone watching, feels the same way I do. Like, you talk about insurance, talk about reimbursement, and you're just like, oh my gosh, this is just like a mountain of papers that I have to read. So it's so awesome to have someone who's so nice and friendly like Alexis to break it all down and, talk about it in I guess general pharmacist terms, we'll call it. So thank you for your time. I appreciate it. And I hope to have you back soon so we could talk about other hot topics in the pharmacy industry. So have a Merry Christmas, everyone. Bye.